A wonderful afternoon to everybody. And again, thank you so much for joining me here today. My name is Jessica Zaring, and I am the Department of Health, Washington State Department of Health's Antimicrobial Stewardship Pharmacist. I am incredibly excited to be here with all of you today to talk to you about a topic that I might be just a little bit passionate about, and that is antimicrobial stewardship, specifically how our wonderful LHJ folks can get involved in this exciting work. First, I just want to quickly remind folks who may not have seen this information yet that the CSTE Antimicrobial Stewardship Workgroup is hosting a conference. It is free and it is an online conference. It does start a little bit early for those of us in PST zone, starts at 7 a.m. I promise you it is very worth it, however, and I will drop the link in the chat once I'm done speaking at the end. Before we get started talking about just the role of public health in general, my own team and what we do, and how our wonderful LHJs can get involved in this great work. The first question that I'd like to answer is why? Why is stewardship so very, very important? Because the why is ultimately the most important part of everything that we do. I want to define the term, however, antimicrobial stewardship for you first. The term antimicrobial itself is an umbrella term. It encompasses antibiotics, antivirals, antiparasitics, and antifungals. Antibiotic stewardship is a more narrow term that refers to just the antibiotic portion of stewardship. Now, we do like to use these terms interchangeably, just to warn you. Most of the time when we're saying antimicrobial stewardship, we're actually talking about antibiotic stewardship. That term specifically means the effort to measure and improve antibiotic prescribing, the effort to minimize misdiagnoses or delayed diagnoses that lead to underuse of antibiotics. A little counterintuitive. Antibiotic stewardship also means that we're encouraging the use of antibiotics when they're needed. The effort to ensure that the right drug, dose, and duration are selected when an antibiotic is needed. Some other reasons why stewardship is important include the fact that antibiotics are among the most prescribed medications in nursing homes, and 40 to 75% are considered inappropriate. 30% of antibiotics prescribed in the acute care setting are considered inappropriate or unnecessary. 30% of antibiotics prescribed in the outpatient setting are considered inappropriate or unnecessary. The threat of antibiotic resistance is real, and that's why we care so much about these big numbers that I just shared with you. I don't need to define antibiotic resistance on this call, as I know you are all incredibly familiar with the topic. According to CDC, each year, antibiotic-resistant bacteria and fungi cause at least an estimated approximately 3 million infections nationally, approximately 36,000 deaths per year. Clostridioides difficile is related to antibiotic use, antibiotic resistance. Nationally, there are about 250,000 cases, about 13,000 deaths. Prior to my role here in public health as a clinician, I got to see what it looks like to be faced with a culture and susceptibility report that shows a bacteria that is resistant to most of our routine antibiotics. It's a scary reality, and it is happening here in Washington State, as I'm sure everyone is very well aware. In addition to antibiotic resistance, there's also a who behind a component of our why. At least this is kind of my why. The who is the patient who is ultimately on the other side of an antibiotic prescription that is given, the inappropriate one, the one that is not needed. In my clinical career as a pharmacist, I have truly been surprised at the damage that unneeded antibiotics can actually cause. In fact, I have seen patients admitted to the hospital solely due to the unwanted side effects of unnecessary antibiotics. My first particular experience involved an wonderful older adult gentleman who was hospitalized for side effects of a very broad spectrum antibiotic known as hernipenem. And so that patient that is ultimately on the other side of an antibiotic prescription, that's one of the who's behind the what. There's lots of other who's, our wonderful clinicians, our opportunity to support them on their own journey towards appropriate antibiotic use. And perhaps there's multiple other who's as well in your personal careers that are part of our why for why this is so important. What is the role of public health ultimately? The big picture, if you will. According to CDC, public health's role is in guiding antibiotic stewardship efforts in various healthcare settings, such as those 3 settings I just shared. Those are the most common ones that we see stewardship performed in. Additionally, our role is also in promoting appropriate antibiotic use for all patients in their communities, that patient on the other side of that prescription. Now, what does that actually look like in practice? As those are very broad kind of big picture role. To define that a little further, I'm going to kind of introduce you to my team here on this slide. There's me. Of course, I'm sure that some of you have seen me in other forums. However, I work with 2 other wonderful folks on my team, Dr. Erica Stowe. She's our antimicrobial stewardship physician, board certified in infectious diseases, internal medicine, and pediatrics. We also have an epidemiologist, Katerina Kamenar. She crunches the data that help us understand where we are needed the most and who we can support the most. We ultimately serve all those settings I shared with you. In addition, we serve the general public and, of course, our wonderful local health jurisdiction partners. We also are here to serve you as well. We create and review clinical guidance that promotes antibiotic use. I'm going to show you some concrete examples of what I'm talking about in just a moment. We analyze state-level data to direct interventions at the local and state level. We have multiple data sources that we have access to. And again, we have that wonderful Epi on our team who is able to help us crunch those data. We also provide high-level infectious diseases and antibiotic stewardship expertise to low-resource areas. Now, the term low resource areas, a lot of us think of rural areas, and that is true, but there are other areas that are low in stewardship resources as well, such as our wonderful long-term care facilities. We have the privilege of being able to serve and support them as well. We also create and promote patient education on an appropriate antibiotic use via social media posts, posters, and handouts. We'll be doing a little bit of that for Antibiotic Awareness Week coming up in November. Now, let me show you some examples of what I'm talking about on this slide. On the upper left corner is a little snapshot of the advertisement for our skilled nursing facility antimicrobial stewardship collaborative. This is a collaborative that we do on a monthly basis. It's an hour-long meeting, if you will, of mostly infection preventionists working in long-term care settings who are responsible for stewardship. They come and they learn from us different stewardship-related topics, different infectious diseases concepts, as we are also, in addition to being antibiotic stewardship specialists, as you saw, we're also board certified in infectious disease. So we talk about community-acquired pneumonia, we talk about skin and soft tissue infections, we talk about urinary tract infections. We do a talk and then we do a practical exercise with them. On the upper right corner, you see a hospital highlight. This is one way that we serve and support our acute care hospitals, actually specifically our rural hospitals. This is a partnership that we do with the University of Washington Center for Stewardship and Medicine folks, infectious diseases specialists who mentor critical access hospital antibiotic stewards. We enjoy the opportunity to highlight the great work that they are doing every single year during Antibiotic Awareness Week, and we'll have some coming in the middle of November. Again, it's one of the best parts, I think, of Antibiotic Awareness Week. Lower left corner is a toolkit that we adapted from an already created toolkit called Prescribing Appropriate Antibiotics for Acute Respiratory Conditions. We call it PARC for short. This is a toolkit that contains advice and resources to help outpatient stewards to set up their own stewardship program and succeed in stewardship. We actually just got through with a project where we funded a couple of different facilities, one rural and one a bigger acute care facility, to implement this toolkit. And I'm hoping that my team members will be able to share on an upcoming LHJ-HAIAR call their findings, because they're really, really cool findings. And on the lower right-hand corner, you see how we serve and support the general public. This is a poster, very small poster, with a couple QR codes on it. talking about penicillin allergies and encouraging those who have penicillin allergies to scan the QR code and learn more about their penicillin allergy. And I'm proud to say that we have this, as you see, in English and Spanish, both. How can we partner on stewardship? Other states, such as Florida, actually, for example, like to use what's called the Module 10 ICAR, which is specifically addressing antibiotic stewardship. This supports partnerships between their state folks and their local folks. What's really nice about the ICAR, which I'm going to share with you in a moment, is that the results can inform the creation of resources at both the state and local level. And also, it ensures that your county's very unique needs are represented and met in our work. With that, what exactly is the Module 10 ICAR? Now, for this portion of my talk, there's going to be a lot of information that I share. And so I'm going to pause a few times as I'm sharing it, and I'm going to ask if there are questions. And please absolutely feel free to drop questions in the chat at that time or come off mute, because I understand there's a lot of terms in here. And my hope is that I did a decent job of pulling visualizations that I can use to kind of help paint the picture a little bit of what this is Module 10 ICAR is asking for. With that, I introduce to you the proactive Module 10 ICAR, the Antibiotic Stewardship Facilitator Guide. This is a form intended to assist the facilitator of a proactive ICAR with assessing a healthcare facility's antibiotic stewardship practices. The nice thing is it's very flexible. You can use it in just about any setting, but not dialysis settings, as it's not set up for that. There are different sections on this ICAR, and we're going to go through them each one by one. And again, I will ask if they're take a kind of a short break after each section just to make sure that they're ask any questions and make sure that I defined all the terminology for you as best as I can. Leadership, commitment, accountability, and stewardship expertise to improve antibiotic use is one section. Action and activities to improve antibiotic use is the next. Tracking and reporting antibiotic use and outcomes, and education of healthcare professionals, patients, and their families. Now, why is it broken up like this? What dictates that these are the sections that should be covered in the ICAR? Think of these as the pillars, if you will, of a stewardship program. Each of these components, leadership, commitment, accountability, separate, two pillars that hold up that building called our stewardship program. These are based on best practices that CDC has set forth as being the optimal way to run a stewardship program in multiple healthcare settings. And that is where these sections ultimately come from. With that, I will kick us off with the leadership, commitment, and accountability section. And so what I'm going to do is I'm going to read through this a little bit, and then I'm going to tell you a little bit about why these are important and define some of these terms. Which of the following individuals are responsible for the management outcome of antibiotic stewardship activities at your healthcare facility? And you see that there's a few choices. There's physician, there's pharmacist, there's other. And that could be an RN, could be infection preventionist. There's also options for if the facility either doesn't know who their lead is or they don't have one. Under each heading, each of the physician, pharmacist, and other headings, we see co-lead, lead, and designated physician support. Now, why? First off, we'll ask the question, why is it important to have leadership, commitment, and accountability? Ultimately, it's important because we do need somebody who is running that stewardship program. We need somebody in charge of that stewardship program who's driving that work. Let's talk about what a guideline recommended, a CDC best practice recommended structure looks like. And then I'll also share with you what you'll commonly see in healthcare settings. So breaking it down a little further, long-term care, what CDC's best practices recommend is that it be a co-leadership model between the medical director, the director of nursing, and the pharmacist. What you'll commonly see is an infection preventionist. In the acute care setting, CDC recommends a pharmacist and physician co-leadership model. And Washington state data shows that what we commonly see is we'll see pharmacists in critical access hospitals in particular. We'll also see a co-leadership model in all other non-critical access hospitals. And this intuitively makes a little bit of sense because our critical access hospitals often are lower in resources and may not necessarily have a physician dedicated to helping that pharmacist co-lead that program. I will share that I used to work in a critical access hospital, and that was my experience in that setting. In the outpatient clinic setting, there's not really a recommended specific healthcare professional that should be in charge because, again, this is what I would consider to be a low stewardship resource setting commonly, unless we're attached to a hospital, in which case the hospital associated clinic will likely dedicate a pharmacist with or without physician co-lead to lead that program. A provider may be in charge in all others. I will share that outpatient clinics, if there is a joint commission, if it's joint commission accredited, it is required to have a stewardship program. Most of the time, you're not going to find necessarily a highly structured stewardship program in outpatient clinic settings. Now, let me pause for just a second. Is there any questions that I can answer related to the terminology I just shared? All right, so continuing on leadership commitment piece. Healthcare facility leadership has demonstrated commitment to stewardship efforts. Now, again, why is this important? When we're talking about healthcare facility leadership, we're talking about the C-suite very commonly. And in the C-suite, there's lots of different roles. There could be a chief nursing officer. That's what we call them in hospitals. There could be a director of nursing. That's what we call them in long-term care facility. We want them to be on board with what we're doing because they can champion our work to their fellow C-suite folks. They can make sure that the folks who are in charge of the budgets understand that there is a need, for example, for more financial support, more FTE support, whatever is needed. So that is why that piece is really important. Now, what does that actually look like in practice, though? It looks like having a policy that requires a program or requires the implementation of activities, allocating resources to support education and training for the team and healthcare professionals, ensuring support for stewardship activities from key departments and groups such as IT or micro, and we're going to talk about these in more detail in upcoming slides. Having a senior executive who served as a point of contact, or as I just shared, champion, we call them champions. Someone who's kind of like cheering you on, if you will, to their colleagues in the C-suite, and ensures availability of resources and key support to implement activities. Having regularly scheduled meetings with facility leadership and the hospital board to report and discuss stewardship activities, communicating to healthcare facility staff about activities, and there's different mechanisms for that. Lots and lots going on here. So let's kind of take it one by one and talk about what these actually look like in different settings. Who does policy implementation in each of these common 3 healthcare settings is what I'll think of them as. In the long-term care setting, the QAPI committee is oftentimes in charge of policy implementation. They're going to be the ones who ultimately write that policy that states our facility has a stewardship program. This is what it looks like. This is who's involved. In the acute care setting, P&T is what we affectionately call it for short. Pharmacy and Therapeutics Committee is ultimately kind of the big one in an acute care facility. Now, there's others. Oftentimes, the bigger the acute care facility, the more committees. They might have very highly specialized committees. But P&T is one that is, I believe, actually required a committee in each hospital, and they are usually one of the biggest ones. They often meet quarterly, which gives good amounts of time to create policies and discuss and pass them. In the outpatient clinic, they're a little more independent. Some hospital-associated clinics may route their policies through hospital leadership, oftentimes because they're sharing back and forth, they're sharing resources and clinicians. And so this can look like clinic leadership, management, they might have provider or two, and potentially others. Now, what does it mean to allocate resources? What does that actually look like in practice? It can look like paying for enrollment in a collaborative in which people come to learn more about stewardship. We have UW-CSIM, for example, in Washington State that is funded by, I believe, the Office of Rural Health. For our rural hospitals, it looks like dedicated time. So essentially writing in someone's job description that they have 0.25 FTE, so a quarter of their time is dedicated exclusively to stewardship. Paying for other resources that help the program, such as software that helps with stewardship activities, continuing education so that they can learn more and be better stewards, or having a consultant come in and actually run the program or do some audits and reports on behalf. This isn't quite in the spirit of allocating resources, but I will mention there are training programs. I will say actually allocating resources for training programs looks like giving money to essentially pay certification rather. The Society of Infectious Diseases Pharmacists has a certification course for healthcare professionals. NADID has one. CDC has a free antibiotic stewardship course as well. What does it mean to ensure support for a program? A little bit of the same as what we just talked about, however, maybe a little bit more concrete in terms of who is involved. Having a champion in lab and micro, for example, that was mentioned in that lengthy description, it's hugely important. The reason why is because our lab is responsible for a lot of the diagnostic tests that detect bacteria. For example, urinalysis and plus reflex to culture being a common test that's a common target for antibiotic stewardship / we call it diagnostic stewardship interventions. Having a microbiologist also on the team is important because they are just brilliant people. Honestly, I actually worked closely with a microbiologist for one initiative in my old hospital. They are brilliant. They know a lot more about bugs than I do by far. And so having them support the stewardship team is huge because they can also ensure lab support as well for efforts. IT support is, in my opinion, critical, especially for our rural hospitals, because a lot of healthcare settings, actually, not just rural hospitals, have competing priorities right now. Lots of hats. People are doing a lot of different tasks. And so having that IT support can cut down on some of that work, cut down on making those reports. They can help customize the reports to make it nice and easy for someone, and then help with creating what we call order sets, which are just sets of best practice recommended orders for maybe a certain condition like sepsis. What does reporting out look like? It looks like being on the agenda for important committee meetings, actually being on the agenda, where the stewardship person actually is talking to that committee about, this is what we did last month. This is our antibiotic data, for example. And in different settings, that can be QAPI, P&T, hospital board, it could be others. I worked with my ED committee in my old hospital setting. Reporting out is also really critical. It ensures that the stewardship program's needs are heard and offers opportunities for others to buy into their efforts, because folks I've found often want to help make sure that these efforts are successful. So when our stewards report out, this ensures that folks are able to offer their support. Now, any questions about any of that material I just covered? All right, so let's now talk about another pillar. This is the action. This is how we are putting stewardship into practice, how we do stewardship. It is, of course, important to have a firm action or plan of action for a specific stewardship goal or intervention, because, of course, without it, we're not going to know what direction the team of stewards is not going to know what direction to go. Now, again, what does that look like in a facility? It can look like a policy that requires prescribers to document indication and duration for all orders during order entry or in the medical record. It can look like facility-specific treatment recommendations for common or high priority conditions. And the top three for us: respiratory infections, the sniffles, UTIs, always UTI, skin and soft tissue infections. It looks like prospective audit and feedback for specific antibiotic agents, formal procedures that review antibiotics 48 to 72 hours after the order. We call that a timeout. Pre-authorization for specific agents. stopping unnecessary antibiotics in new cases of C. difficile infection, assessing and clarifying documented allergy. Additionally, there's some other suggestions down here, review of outpatient therapy, although it was kind of in the spirit of the question that was asked earlier, but this is actually parenteral, so IV antibiotic therapy. Stewardship that's happening on the discharge, at the discharge step, which I'll talk a little bit more about what that looks like on the hospital side. And collaboration with microbe. So again, lots going on here. Let's break it down piece by piece. First off, let's define what an indication is. Having an indication on the prescription, it looks very different depending upon which electronic health record is being used. Usually when the prescriber is typing in that order for, let's say, cephalexin, we stewards can actually tell our computer program to require them to tell us why. So the indication, what is it for? Unfortunately, this requirement for an indication is often only present on hospital orders. Sadly, it is not an option that we can switch on always for those orders that are going outwards to a community pharmacy. And so that's a little bit what that looks like in practice. What's nice about requiring an indication in the electronic health record is that it allows for stewards to run a report really easily, pull a report that tells us these are what these antibiotics are being prescribed for. And so that helps the steward in the hospital setting to know that this needs my attention, for example, because this isn't the best antibiotic option for, I seem to like cellulitis. So we'll just stick with cellulitis. What do facility-specific treatment recommendations look like, and what are they? These are based on local antibiogram data or national guidelines. You'll find these more often in acute care settings than in long-term care settings because these are based on local antibiogram data. Ultimately, what we're doing with facility-specific guidelines is we are taking what's recommended in national guidelines and we are making sure that our local organisms are targeted by those, if you will. And so on the bottom, there is a screenshot of an example of institution-specific guideline or facility-specific. This is from UCSF. I have my previous role, created my own in a Word table. It can be very, very simple. Essentially, it's just taking into account your local bug population, if you will, your local resistance data, making sure that those antibiotics are working effectively for the right patient population. And so you can see in this one, they have condition there, community-acquired pneumonia, what are the major pathogens, what's our recommended antibiotic therapy, what are some alternatives for situations like a penicillin allergy, or maybe kidney dysfunction is another one, and then just general comment. Now, let's do some more defining of different stewardship actions. Prospective audit and feedback. This is a term used in a hospital setting. We call it handshake stewardship, colloquially, because of the in-person nature of it. It is a very personal, in-person rather, intervention. What this looks like is reviewing antibiotics and then making recommendations to the prescriber, often in person, sometimes over the phone. This can be reviewing antibiotics that are on a report that's generated every morning. It could be reviewing antibiotics typed into a Word table, which is what I did back in my old clinical days. This is not a timeout. The timeout is a term that you'll find used in long-term care settings more commonly, and I'll define that in a moment. The reason why it's not a timeout is because the stewardship team and not the treating team is the one taking this action, prospective audit and feedback. This looks like there's a lot of different ways to do this. In a small hospital like what I used to work in, I had few enough beds to where I could review the antibiotics of every single patient every single day on my report. In a really big hospital, you can imagine that would get very lengthy. And so what some folks may do in those settings is just look at antibiotics that are prescribed to patients on a certain floor, maybe in a certain section of the hospital. Maybe they don't do it every day. Maybe they do it every other day, or maybe they do it once a week. It's customizable dependent upon the facility. As I said, this one is typically seen in hospital settings. In our long-term care facilities, this is where we're going to see the timeout. This involves reviewing antibiotics. Typically 2 to 3 days later, the treating team will do this. Oftentimes it's the infection preventionist who's helping with the timeout. The reason for 2 to 3 days is because that's how long it takes for the culture results to come back. The reviewer is then going to reach out to the prescriber, often via telephone, because providers in long-term care are often off-site, to ask if changes are needed or if that antibiotic needs to be stopped. Pre-authorization, commonly seen in bigger hospitals. This is a process in which a physician cannot prescribe certain antibiotics without getting the okay from infectious diseases experts. Like I said, this is usually used in bigger hospitals. They're typically going to use pre-authorization only on very select antibiotics, and those are going to be very, very broad, special antibiotics that target specific MDROs. Carbapenems are what come to my mind. Those are oftentimes restricted to pre-authorization in bigger hospitals. This can be a systematic process. Typically, you'll have an ID physician that runs the pre-authorization service, but you'll have a pharmacist, for example, or maybe a fellow that takes the initial calls and requests for okays to whether or not it's okay to use, for example, a carbapenem for this specific patient. And then the pharmacist can, of course, consult that infectious disease physician if there's questions or if that patient falls outside of criteria. Discharge stewardship. So I talked a little bit about this already earlier. So this is often done in hospital settings. As I said before, in that community pharmacy setting, there's not stewardship typically done in those settings just because there's a very severe limitation on technology, and oftentimes communication of indication doesn't occur. Additionally, there's also a lot of time constraints as well. I actually used to be work in the community pharmacy setting a very, very long time ago. And oftentimes the pharmacists in those settings do not have a lot of time, unfortunately, to do separate projects in addition to filling prescriptions. Discharge stewardship can look like meds to beds, where you have a inpatient pharmacist or intern pharmacy student who hand delivers medications to the patient's room and then counsels them on how to take it appropriately. There's also discharge consult services where that's kind of the same thing as what I described, only the pharmacist isn't delivering the medication to the patient. Review by pharmacists of discharge antibiotics. Review can happen in the moment or it can happen later. It's probably more common that it happens later when we're pulling a report that tells us, once again, we're looking at antibiotics, for example, for cellulitis, and we're seeing that a lot of the prescriptions that were sent to that community pharmacy in town are for an antibiotic that's not the first choice, or maybe it's being prescribed for too long. And then we would basically go back and recommend to the providers that maybe we could try this instead, maybe we can try this duration instead. What do you think? Something like that. Review of OPAT is also done in hospital settings. This is review of discharge IV antibiotic therapy, and this can happen in the hospital before that patient is sent out to the facility, or a review once the patient is received by the OPAT facility. That's going to happen more commonly in a bigger hospital where that OPAT facility is part of the hospital. We talked a little bit about how crucial collaboration with micro and lab is. As I shared before, and back in my clinical role, I have done collaboration with micro and lab, and they are just incredible partners to have when you're trying to focus on some sort of stewardship intervention that involves education on the appropriate use of a test, urinalysis with reflex to culture being probably the most common target. Any questions before I go on to dedicated time and resources? All right. And so this section of the ICAR asks, which of the following describes the individual responsible for the management outcomes of stewardship activities? And it breaks down whether or not there's time present in the job description. Do they have responsibilities in their contract, job description, or performance review? Are they telehealth, essentially? Are they off-site doing recommendations over the phone to somebody on site? Do they have training? Have they completed antibiotic stewardship training, infectious diseases training, etc.? Now, again, why is it important to have dedicated time written into the job description? Because this is having it written in the job description, contract, etc., is one way to ensure that that person does get the time they need to do the work. Now, kind of continuing a little bit on that same vein, we'll talk quickly about tracking and reporting now. And this is kind of what that person does. So the healthcare facility tracks antibiotic use by submitting to CDC's NHSN Safety Network antimicrobial use option, using reports that are printed by the electronic health record, using pharmacy data, submitting to a antibiotic stewardship collaborative or public health organization, and I'll share with you kind of some efforts we've done in that area. Manual tracking, this is going to be using an Excel form most commonly. Or no, the healthcare facility does not track antibiotic use. Now, let's start by kind of showing you a picture of NHSN AU, in case some folks here may not be quite familiar with that. But this is CDC's National Healthcare Safety Network software. And so again, some folks here may be familiar with this already, but there is a section in there that is dedicated to antimicrobial use tracking. And this is for hospitals. There is something coming up for long-term care facilities. There's still work being done there because CDC wants to try to find a way to automate that collection process, which will make it really nice and easy for our long-term care facilities who are under-resourced. Now, this tracking, it is automated, but the hospital actually has to put some work into pushing the reports to NHSN. And they often have a software vendor that will collect antimicrobial use data from the EHR and then push it to NHSN AU. What's nice about NHSN AU, you can see from this screenshot on the right-hand side a little bit, there's folders, different folders, and in those folders are different reports. And so once those data are pushed to NHSN AU, the hospital can go in here and they can print reports that shows their antibiotic use. Now, I'll show you what Washington State Department of Health does to help our stewards with tracking and reporting specifically related to NHSN AU. So some folks here may have seen the dashboard that our EPI, Katerina Kamenar, is responsible for and created. This was intentionally designed to make it as easy as possible for our stewards to be able to track and report automatically with ease their antibiotic use. And what's beautiful about this is you can select within this dashboard the different antibiotic options, what you want to see with your medication. This is tracking a rate of antimicrobial days per 1,000 days present for ceftriaxone and a couple other drugs at the bottom, doxycycline and azithromycin. What we love about this is that the facility can screenshot this and put it in their monthly report, and they're done. It's that easy. This is one way that we are very proud to be able to help our stewards, especially our rural hospitals who, as you are well aware, are low in resources and need that extra support wherever they can. This is a dashboard that only facilities reporting into NHSN AU can sign up for, because of course we take that NHSN AU data and give it back to them in the easiest and most beautiful way possible. It's a point of pride for our team is that we work really hard, so the resources that we make, we try to make them as pretty as possible. Now, that is an automated tracking example that I just showed you. There are other automated tracking examples, but they are really specific to the electronic health record and the software that the facility is using. Other methods of automated tracking are just printing reports on a monthly basis. Reports can be as simple as a word table as well in the computer that is printed, and those can look a lot of different ways. This is an example of what manual tracking looks like, and this is for a nursing home. This picture I'm showing you is an infection and antibiotic start log template. This is really nice and easy for IPs who may not have access to automated tracking, which nursing homes do, oftentimes through their electronic health record, kind of like acute care hospitals, but some don't. And for those facilities, having these types of databases is really nice, because then they can just plug in their numbers and it gives them this beautiful Excel graph. And on the top left-hand side, the words are a little bit small. but it shows some metrics that these facilities commonly track. Antibiotic starts is a really common one for them to track, and that's denominator is 1,000 resident days in this dashboard. Also, they may look and see if their facility is utilizing their own institution-specific criteria. For UTI is the most common target. Oftentimes, UTI interventions are done using what's called an SBAR tool. And so the IP may, at the end of the month, just audit and make sure that the SBAR is being used, that certain criteria were being followed, and then they may turn and give that feedback at QAPI committee of this is where we're at in terms of our SBAR and UTI prescribing. So that is an example of manual tracking. Any questions on that before I go on to policies? Okay. What do facility policies look like? Now, I have to say not everything necessarily needs to be in a firm policy, especially in an acute care setting and a long-term care setting, actually. There's different ways that we can put our stewardship interventions, is different areas we can put them into, such as a set of orders that a provider initiates when a patient is admitted for sepsis or urinary tract infection. We can put interventions in there as well. Facility monitors adherence to the following stewardship activities, and some of these we've already defined. So documentation of indication and duration, facility-specific treatment recommendations, prospective audit feedback, that timeout, pre-authorization, and the facility provided prescriber with antibiotic use reports within the last 12 months. This can be at the level of the prescriber individually. This could be facility, unit, clinic, or service specific, or perhaps another way that's not listed. Now, it's important to monitor adherence, of course, because there are data that show that passive education, just briefly talking to providers or any group of healthcare professionals, for example, is not effective on its own. Monitoring adherence and giving that feedback through reports is ultimately what kind of helps reinforce that policy or protocol that we've put into place. And that's why those are on there, and that's why those are so important. Now, what does monitoring look like? We've kind of touched on this already. EHR reports that show antibiotics prescribed by hospital room, bug drug mismatches, antibiotic indications, antibiotic starts, days of therapy. Those pictures I just showed you could be a way to do monitoring. Some bigger facilities use dashboards, really, really nice, beautiful dashboards. IT help often needed to set those up, however, and so as a result, not every facility may have the ability to access tech to create dashboards. These are oftentimes matched up, the data themselves are matched up to facility-specific treatment recommendations or used for that prospective audit feedback. Manual reports include those Excel files, Word tables in which antibiotic use and cultures are tracked, and then peer-to-peer comparison reports. I'm going to show you an example of that in just a moment here. And there it is. Peer-to-peer comparison is a behavioral intervention, ultimately behavioral science intervention. It's a nudge, if you will, to encourage responsible use of antibiotics within a certain context. And this is just a little picture that I just kind of generated really quickly of what this might look like. Peer-to-peer comparison. So what we're looking at is just a pretend, these are all pretend numbers I put in, table or graph of showing number of prescriptions written for acute uncomplicated bronchitis in March 2025, and it's broken down per prescriber. And so you can see prescriber Y is the lowest. Now, with acute uncomplicated bronchitis, that's a diagnosis that does not require antibiotics. And so the ideal number of prescriptions is technically 0 for that. And so we're looking at prescriber Y and we're thinking, oh, prescriber Y is doing great, but prescriber X is kind of on the higher end of the spectrum. And so peer-to-peer comparison reports are used sometimes in some settings to encourage friendly competition, right? Just kind of friendly competition at either the unit level or the individual prescriber level. Like, let's see who can do a better job, if you will, or who can get their numbers lower. So it can be seen as a fun competition in that sense. Or it can be reported in a committee. It may not be reported at the prescriber level in the committee setting. It may be anonymized, kind of like what I show you here, and maybe only the chief medical officer has access to individual names. Some facilities will send out reports that are, again, beautiful dashboard type reports that break down, these are your exact numbers for the month, a lot more detailed than what I'm showing you here. But ultimately, there are data that support peer-to-peer comparison as a great way to give stewardship feedback, and that will lead ultimately to improvements in antibiotic prescribing. So this is also another form of peer-to-peer feedback, if you will. It's anonymized peer-to-peer feedback because, of course, these are facility data. So this is our dashboard, again, showing you facility location. SAR is just a metric that's used by NHSN, essentially antibiotic use metric by bed size. And so our facilities can look at other facilities within their bed size grouping, and they can compare themselves. And again, being able to compare yourself to your peers is very powerful, especially for our stewards who are doing facility comparison. They can screenshot this, take it to their P&T committee, and say, this is an area that maybe we need to work on because we are higher than our peers, for example. It's very powerful data. All right. So I will kind of move through education really quickly here. Healthcare facility provided education and training on optimal prescribing, antibiotic adverse events, and antibiotic resistance within the last 12 months to healthcare staff, essentially, prescribers, pharmacists, nursing, patients, and families. Now, education is important because we want everyone in our facility, all of our team members, to understand the importance of what we do. And we also want them to be on board with what we're doing and be excited for the work we're doing as well, especially our patients and families. I will say education for patients and families, or residents and families, is extremely valuable, or not just valuable, but especially important in the long-term care facility setting. We get a lot of requests and expressions of interest in education in that group. Now, here's some examples of education. On the left-hand side, this is a provider education that my team created here, specifically on urinary tract infection, which is an area that has a lot of questions. Additionally, the top CDC's antibiotic stewardship courses. This is for healthcare professionals and providers here. It's free, which is really nice, and has free continuing education. In the middle, the Centers for Stewardship and Medicine Collaborative for our wonderful rural hospitals. And on the right, an antibiotic guide is kind of a type of education. It's probably a little bit outside of the spirit of education, but it is a resource that can be disseminated to assist our providers with their antibiotic stewardship journey. On the left-hand side is an example of a patient education, of course, CDC's handout there. And on the right-hand side is a YouTube video education that our team designed for patients, residents, and their families, and that talks about urinary tract infections in women. Health education is provided to healthcare professionals during that handshake stewardship intervention. For example, when I would go in my hospital to make a recommendation for a provider, oftentimes I would like to share why I was making the recommendation. I would perhaps start with, I noticed this patient is on an antibiotic that's not necessarily the first line antibiotic for community-acquired pneumonia. What do you think about changing to this one, which is recommended for community-acquired pneumonia? And so sometimes my explanation may need to be a little lengthier if the provider wants to know a little bit more, but that's one way to really, really quickly do some education. During certain meetings as well, perhaps there's a staff meeting. Oftentimes during staff meetings, there might be somebody who provides just like a quick 10 to 20 minute educational session. That can be a forum. Conferences, of course. Webinars that offering continuing education are an option. Via email, I would say the email is probably not the optimal way to provide education, but it is an option for folks. Educational modules assigned by the employer. This is a really common way to educate whole entire facilities on a topic such as antibiotic stewardship. Academic detailing is a term that essentially just means one-on-one coaching, if you will, where you're sitting one-on-one with a provider, or your facility steward is sitting with the provider and they're making direct recommendations or sharing direct feedback on something specific. For patients, it's provided during appointments through handouts, before the appointment, posters in patient care areas, handouts on tables, videos in patient waiting area, or in the community, tables at health fairs and posters. All right, I shared a lot of information today. So some tips for success that I've learned from wonderful folks at Florida that I'll pass along is to make sure before going to the facility, it's good to make sure to review that Stewardship Module 10 ICAR. It is a bit of a lengthy document. I will say because it is lengthy, one other approach to take to the Module 10 ICAR is if there's interest in utilizing it, maybe pick one or two questions to start with, for example, to kind of break it down in a simple manner. Send the Module 10 ICAR to the facility ahead of time. The reason for this is because sometimes the stewardship lead may not be immediately available during the proactive ICAR. So sending that to the facility ahead of time, make sure that all those folks are available when time for the ICAR has come. Implementation examples as well is something that my colleagues in Florida in particular have found to be helpful. So kind of like those pictures I showed you a little bit earlier with those key terms, if you need examples of what a stewardship intervention looks like in practice, me and my team are always here for you. Additionally, positivity and encouragement always goes a really long way as well in all proactive stewardship ICARs. Our team, as I said before, we're here to serve you. We enjoy helping all of our wonderful stewards throughout Washington State. We really do. We can be consulted for complex facility questions raised during the ICAR Module 10, or we can be consulted for any question you'd like in general. We also offer many, many resources on our website that you can share with facilities very easily. We can also give general stewardship advice to your facility at any time. We can also help if there's a desire to create some resource for yourself as well. If you decide to do Module 10 ICARs and you find in your county that there's a lot of different folks requesting a resource, we are here to advise you if that is something that you are interested in or need. Again, we're here to help. Please feel free to reach out to us with any stewardship related question or need. I've got for you a couple of links there to some resources. In case you're interested, CDC and our website, we have subpages for nursing homes, acute care facilities, and so much more. We also have resource bundles classified by settings, or excuse me, CDC has that, not me, and different healthcare professional types as well. And there's our contact information if you have questions or comments. And that is what I have for you today. And I'd like to thank you so much again for spending this last hour with me